Hi, welcome back to round two of the Tricuspid Regurg TR2 Innovation and Cases. What an exciting morning we had. And so it's with great pleasure to start with Brinder Kanda, who's going to present a complex transcatheter tricuspid repair.
Thank you, everybody. So we'll get back to the case really quick. So 48-year-old woman who was initially had a sternotomy many years ago for rheumatic valve disease, had a mitral valve replaced with 29 magna and tricuspid repair with Edwards Classic ring, number 26. It's a rigid ring. She has a non-ischemic cardiomyopathy, had a defibrillators placed, was doing well, then started developing heart failure. She developed some cardiac cirrhosis, Child-Pugh score B and MELD score of 9. She's severe TR, went to outside facilities and attempted valve and ring. And you can see the valve is a little bit outside the ring, and the tricuspid valve, the AICD lead is pinched behind it. So on the right side, that's the mitral valve, then ring on the left side of the screen, and the sapien and prosthesis is holding between the AICD lead and the mouth of the ring. According to the records we received, they discussed it going open, but patient seemed to be prohibited risk for surgical management, so she was discharged home to follow up with her cardiologist. Patient presented a week later to the ER with the AICD lead malfunction and acute decompensated heart failure. They implanted a new lead through the new THV, IV diuresis. They contacted us, said, okay, diuresis, we'll see her in the clinic. But unfortunately, she has 4 hospitalizations, so she went information transfer to us. When she came to us, we did a prehabilitation for 1 week, IV dobutamine, IV diuresis her 12 liters. We have multiple people see her in the liver team. We do something called liver elastography that my GI guys tell me they can tell me if the cirrhosis is bad enough we shouldn't do it or there's some reversibility. So because of her young age and there was some elastography positive finding, we thought we had to do something about it. So we did a TEE. You can see there's an ICD lead that's impinged behind the prosthesis. The ring is there and there's a prosthesis and there's TR from the THV and from the prior ring. I think that's a lot of TR. So we optimized her. We thought she's 1 week is good, and then we did a right heart catheterization. You can see the swan. It was very difficult to get a swan in. I actually used a gillis and a wire and get the numbers up. So the wedge pressure was about 20, RA was 24. PA pressure was not horrible. The CT scan showed, I didn't put all the CT pictures, but basically showing where the malposition THV is and the ring is, and on the video of the CT showing it's kind of tilted towards the coronary sinus. This is the initial CT from Edwards we got it when the initial workup was done. From the ring, the area was about 360. This is from our favorite app that tells us that, you know, we size there, but it's a rigid ring, be careful. So what do we do? We designed the procedure for her. We decided to go with general anesthesia. We decided to stabilize the malposition THV from the groin. IJ, we planned the approach to go from the IJ and just go with a preload valve with a 24 dry seal. No pacemaker, we didn't think we need a pacing. We had a backup as ECMO or BiPALA. Our surgical colleagues were kind of in agreement. If she's very young, if we're going to give it, we're going to give it all. We didn't think we have room for ice in that atrium with all that stuff. So this is first wire. We crossed with the gillis very carefully, exchange it for Safari over the soft catheter, and put a true balloon there. And you can see I already have, oops, let's go back. The IJ sheath is there positioned. The second wire was crossed from the IJ, exchanged for Safari X small curve wire. We inflated the true balloon to anchor while we're crossing the valve to make sure we don't rub it in, push it, send it to the RV or the other way around. Once we positioned the THV inside the ring, we couldn't see it with the inflated balloon. So we had to deflate the balloon at this point so we can see the landing zone. This is a very slow inflation, painfully slow, no pacer, but she's tolerating it so far. I still have a true balloon in the other malpositioned THV. In case this moved, the plan was to kind of inflate it that time and stabilize it. This is what it looked like after inflation. So the oval shape looking is the prior THV, and there's a new sapien. TE images were okay because there's so much prosthesis, there's so much leads, but there's not much TR left. This is her 1 month post-discharge echo. I actually called the primary cardiologist this morning. So far, she's staying away from the hospital. And the mean gradient on 1 month echo is 3.3. So key learning for me for this case was that space around his space or the pouch. I think that's what we need to count for when we have rigid rings. Do we do pre-dilation? I'm not sure if that pre-dilation rigid ring in this made a difference first time or not. And pro-jugular versus femoral axis. That's all I have for.
Oh, this is an unbelievable case. So let me ask you a question. And we all, when we do those cases, we all wonder, what was the level of confidence before the case that, the strategies, I mean, clearly you thought about it. You thought about plan A, B, and C, and what doesn't work. But what was the confidence level, before you do that case? I mean, that you're going to be able to be successful in implanting sapien. Because this is a common scenario. I mean, this is the second case that was presented today with the ring out pouch on the septal side.
So family was very involved. That's a good thing. They know. I never done this before. This is the Hail Mary. We can give it a shot. They understood, and then the morning of the procedure, I have everybody in the conference room. I said, there's a lot of things going to go wrong today, but hopefully we can save it. If anybody feels it's stupid, we shouldn't do it, But everybody was, the anesthesiologist was very enthusiastic. He's a mitral clip imager. I had 2 underwears on, so in case. I mean, there's uncertainty in this case, but I think we had a good team and good plan. I think we could execute it, so.
I mean, this is fantastic because, quite honestly, this is what a lot of people sometimes neglect, is to get the team together, for those cases. Clearly this was wonderful results, but it could have been, different. And I think, the putting the team together was just unbelievable. Paul, any comment on this case?
I think you and I chatted a little bit around the time you were doing this case, and I said, yeah, sounds great. Good luck. So, but there are a couple of things that are actually quite remarkable. First, these incomplete rings, just by itself, the results are usually not good because you can often have PVL where it's incomplete. And, I've had cases like that, and it's for the tricuspid, it's really, really challenging. So solving that was actually an important piece that was easily overlooked because of the other complexities of what you did. But that anchoring balloon and such, I mean, so my question for you is, do you think it made a difference going IJ for the valve and balloon from the femoral? Because I would have done, honestly, I think I would have done differently, but I would not have had any more confidence, as Firas alludes to. How did you choose which way to go?
So the first THU was done from the femoral, so I think they have a trouble. So I said, we'll go from the IJ, make it simple. And the angle was very favorable. I thought we were going to rub it against it, but it just, once we had the balloon up, it just went up. We deflated the balloon. We couldn't see anything behind it. But that's the only reason I chose the last time they went femoral. Yeah, so I said, we'll go IJ.
And what size balloon did you use?
For TH20.
20.
20,
Paul,
true.
I really, that's a fantastic case, honestly. That's a really, really remarkable result. I do like the strategy of going transjugular. I think the angle is going to be more favorable for us in the tricuspid replacement space, generally speaking, like largely speaking. I think there'll be devices that come out that are transjugular because the angle is so much more forgiving and favorable for getting a stable valve that's coplanar and coaxial.
Agree.
One of the things that I want to ask is this, ICD management. Since the first ICD lead failed, why the decision to put another ICD lead versus using another, sub-Q ICD leads to prevent these problems from happening?
So, good question. I actually don't know. They called me, that patient depended, where should we put the lead? And I said, where you can get it. I'm sure they have the facility she was in, they have a sub-Q. I think she's pacemaker dependent, and the LV pacing was not enough. That's my guess. So they put it here through wherever they could it the second time.
Because a lot of discussions are coming about leads and tricuspid valve replacements and what will be the optimum things, how to be involved. And this is the importance of including EP in the planning also for the heart team procedures.
So we actually had an EP. I told him if I mess up the new lead, again, he told me it's fresh lead, we can get it out of reposition. So they were part of the discussion as well. So you're right.
And your thought, your approach with the team, having pre-procedural planning, having a strategy, having everybody on board, I think that's so critically important. And then setting expectations with the family members. This is not something we do every day, right?
Yep.
So I think those two things are critically important. Having a plan A, a plan B, and a plan C with a bailout for each of those percutaneously.
Absolutely.
I want to know what the plan C was.
No plan C.
So we have a minute for one question, and in the last session, Steve Bowling said electrophysiologists are afraid of surgeon, and I appreciate that. But then he said surgeons are afraid of the AV node, and I also appreciate that. I mean, I have a question. I see Moritz in the audience. Moritz, are we gonna change the way that we repair the tricuspid valve surgically to address some of those issues from surfacing in the future? I mean, you were with us the last session, and the failure rate is Steve presented was like 5% over 5 years, but it seems like when they fail with this mechanism, it becomes very, very challenging.
Yeah, I mean, mitral, tricuspid valve, complex valves, right? And ultimately, the advantage we have as surgeons is that we can address all parts of the valve, while with transcatheter therapies, you typically do one or the other, but not really addressing multiple components that typically contribute to TR. And that's true for primary MR-TR, but certainly even more so for functional. And keep in mind that for functional, the surgical results are not as good as for primary, and the same is true for transcatheter. So there's, two levels of complexity, if you will. One is what can you do, surgery versus transcatheter approach, and secondly, what kind of a pathology is it, secondary versus primary, MR or TR, and so, if you look at most TR being functional, you're trying to overcome pathology that's really the ventricle where is the issue, and you're trying to do that with a one trick pony, if you will. So, what is needed to get better results and more consistent results in the transcatheter space is, probably a pathway where we are able to treat more than just one thing in a way that's feasible from a technical standpoint and people learning all the different devices, but also economically sound. And that's certainly in the first session this morning I was thinking about all the great things that have been said, and we're looking at the tricuspid technology that's coming down and how we're going to make this work as a hospital on a system level. The reimbursement barely covering the device, then you need ICE, on top of that. You may need and end up getting a pacemaker. I mean, it's complicated. So it's really hard to do from, that's the end point. But again, it's how many things can you do to get to a durable result, and with surgery we just have that advantage of being able to do multiple things. We look at it directly. So I think those are my thoughts on that.
That's wonderful. Thank you. Brinder, that was a wonderful case.
Thank you.
And our next speaker is going to carry on the same theme and discuss a tricuspid valve-in-valve challenge. Seun, Alli, thank you very much for presenting your case. And give you.
Thanks, Paul, and the organizers for having me here. I don't have a sexy case as Brinder just presented, but something along those lines. So I'll be talking about a case of a tricuspid valve ring. So this is a lady that I've seen for about 8 years now. I think I met her in 2016 or 2017. But she came, she had a bioprosthetic aortic valve replacement in 2005 and did well, but the valve failed and had a reoperation. At that time, she had severe TR and severe prosthetic aortic valve stenosis. So she got a 25 Magna valve and a 30 millimeter ring on a tricuspid. She did do poorly immediately post-op, RCA occlusion with RV dysfunction and cardiogenic shock. So she went back to the OR and got bypassed to the right corner. The left main was fine. She did develop severe MR. We had put a clip on her. She did well with that. Had an ICD placed through the ring and got a LAC device for recurrent GI bleed. But she did okay until a few years ago when she developed worsening heart failure symptoms with shortness of breath and edema and fatigue. She had severe TR. So these are the images. As you can see, the right side is on the left side. She's got the ICD lead going through, and she's got significant TR. So the question becomes, what do we do? How should we manage this? We thought about replacing the valve and ring. What will be the risks? What will be the chances of a PVL? She did not have a big outpouching like Brinder's case, but based on an imaging, but we knew that we may have PVL around the ring, around the valve once we put it in, especially where the pacemaker or the ICD was going through. So we, as you can see here, she's got a few things in her heart. You can see the ring. We went femoral for this. We've got a wire in the left pulmonary artery. We deployed a 29 S3 valve with no major issues, and that looks really good. No problems. Actually used transthoracic imaging for this case. Once we put that in, we did have some perivalvular leak on the middle aspect where that pacemaker was coming from the ICD. This was read as moderate perivalvular leak, and this is what we had. Now, the guys on the panel, will anybody do anything differently? Would you close this at the time on the table? Would you let her be and see how she does? Or would you do something different?
Anyone on the panel?
No enthusiasm. A few years ago, and it was moderate, it wasn't severe, and we decided to bring the patient back for relatively, compared to what you just did, straightforward, stage procedure. But I don't know that you can't just go ahead and plug it at this time. You have all the imaging in place. You said that you did not use TE for this?
No, we didn't use TT.
Maybe that would be a consideration, because
Yeah.
maybe I'm wrong, but I think I would use TE for plug, but yeah. Yeah, I agree. I think I would probably plug this on the table. This is a moderate eccentric PVL. I think this would be one TE probe down, get good imaging, and try to plug it if you could at the time.
Yeah, so the biggest information that I would like to know is the leak is coming because of the valve, not positioned correctly. The skirt, is not covering the ring completely. That's why you have an intravalvular leak, or is it a true PVL leak coming from outside the valve. So this is where the importance of having a TEE is very, very important in this decision. Cases where we have, just because the valve landed up a little bit high, we end up putting a second valve in, and that seems to be taking care of it completely. Cases we had a leak like that, we sometimes try to plug it at the same time, depending on how severe it is and how does it look like. If it's not severe, then we leave it alone.
I think the comment about skirt PVL versus outside the valve is actually very important, because if it's a skirt PVL, you going in and out through this valve, you could dislodge this, because a skirt PVL, ideally you put the plug on the inside of the valve and pull it against it and make sure the whole track is covered. But if it's a PVL outside the sapien, it's probably safer to go back and forth. So this to me looks like it might be a skirt PVL, just where that PISA is coming inside the valve and some of the views, but I think a T would be really helpful here. So
That brings up something I forgot. So would you ever have a buddy wire in the place where you fully anticipate there should be a leak and an incomplete? I mean, there has to be a leak there in a way. Would you ever have I've done that now that I remember back, especially given your concern about traversing that area back and forth, if you're fully committed to it.
I would have a buddy wire, and also I'd have a wire across the sapien in case you dislodge it, because if it flips, you need to be able to control it. So I would have all those things in place. So how'd you solve this?
Yeah, so we felt it was moderate. We didn't do this case with TE, so obviously this was TTE grade, but we elected to see how she did. So that's what we did. But she did okay for a few weeks, but came back with more heart failure. This is a TEE done now. So clearly the PVL is outside the valve, and it's close to that pacemaker ICD device. So we brought her back, and we'd like to close this. Closing it was fairly straightforward, and I have an Agilis. As you can see, the valve is well seated. The sapien is seated nicely in the ring. I think we got a good position of the valve. And then we ended up putting, and left a wire across, and we went in and put in two, I think 14mm AVP2 devices in there. And this is post-imaging with TE. You can see the devices there, and significantly much reduced PVL. So, I mean, for me, for us, the learning point here is this can be technically challenging. We've seen a case where there was a bigger pouching that needed a second valve. PVL is obviously more common. The issue with tricuspid valve and ring compared to valve and valve is the issues with geometry and the variability of the rings. Flexible, fixed, stiff, whatever they are. PVL can be very common. You could embolize the valve. You could end up with heart block. We've seen cases where the pacemaker was pulled out once you deploy the valve. But when you have significant PVL, you can definitely close it. I do agree that probably this should be done with TE and done on the table to take care of it at one time. If I had to do it again, I'll probably do that. Get it done.
Yeah, that's a great case. So could you go back one to your fluoro? I think we could talk about transjugular access here too, but if you look at that, and we can maybe go back and talk about it, but even before that, you see how that transcatheter heart valve is shorter on one end and longer than the other. That often, or that could potentially lead to some early valve deterioration. Did you give any consideration to post-dilating this valve?
It was post-dilated.
You post-dilated with a true?
Yeah.
Okay.
Yeah, but to your point, Mark, if you look at the anterior side of that, you didn't have skirt PVL, but you almost did. So look, if you look at where the lucent line on the sapien is, the skirt is really close to the top of that ring. And so it's kind of interesting how you didn't have skirt PVL there.
But going back to transjugular, though, again, look at the angle of the annulus here.
Yeah,
look
so I was going to ask you, Tom,
right?
so it sounds like you've done these more from transjugular. Do you think this would have been fixed?
Percutaneous 2 perglides. You can do transjugular very well if it's about 9 millimeters by ultrasound. This would be a perfect angle for a transjugular case, THV.
And on your image, when you were deploying your fluoroscopic image, you were real canted. Sometimes it corrects, you get lucky, and it's great. And you obviously didn't suffer from this because you didn't have PVL at that site. But yeah.
So I've never perclosed an IJ. We just figure rate it.
Two percloses.
Two percloses and an IJ.
Yep.
All right.
Yep.
There you have it. I'm going to say Tom.
If the vessel's about 9 millimeters on ultrasound, we do our CTs from jugular to hepatic for all of our tricuspid valves, whether it's a trial patient or a commercial patient. And CT, it's a 9 millimeter, 9.5 on ultrasound. It's 9 millimeters, so you can do 2 proglides very nicely.
Or even just one.
Anybody else proclose IJs?
No.
Brinder? Anybody else? All right.
No.
This is
Surgeons,
great.
figure of 8 the IJ all the time when they put the Avalon cannulas and all these things. So it works and cheap.
It's much like the transfemoral, right? So your mitral clip systems, your Pascals, your TTVRs, TMVRs, everything you do from the groin. If it's 24 French or less, we use a single proglide for venous. If it's 24 French or over, we do double proglide, whether it's jugular or femoral. It works very well.
Would you use CT to judge in terms of which axis? Yeah.
Interesting. So I'm gonna just have a one controversial comment to to finish with. This is a wonderful case, but it illustrates our desire always to eliminate TR with TTVR. Whatever we do, the expectation there will be no residual leak. And I think somebody might say, well, what is the risk of PVL? Is it hemolysis? Probably less than than it is with mitral. Is it hemodynamically tolerated? But I think we're all in that mentality, and I think that your case just support this train of thought, is that we should eliminate TR with TTVR, and this is the expectation. So thank you for demonstrating that today.
Nice case. Good job.
And now moving on to one of my favorite imagers, Richard Bay, who will be presenting to us a new tricuspid imaging window.
Thank you so much. Thanks, Paul, for having me again. And Paul always gives me these crazy topics, so a new tricuspid imaging window. And I've been thinking about this, and I don't really have anything, so that's pretty quick. So, I was thinking about rehashing, the upside down transgastric. Paul calls it the Bayview, but I mean, I've shown that before. So this is more of a thought and a recent kind of experience that I had, and I know that people with more experience in this realm may have some additional comments. So I changed it to a somewhat new tricuspid imaging window for transcatheter tricuspid valve replacement. So this is just a recent case. Very nice imaging, transgastric, and you see the TR there anteriorly. And you see the mechanism here, anterior flail segment with just a big gap and torrential TR. Here's the short axis color. You can see the majority of that TR is coming anteriorly where that flail is. But reasonably good imaging. Now you can see that the heart is somewhat horizontal. So in the orthogonal view on the right, you can see that the tricuspid annular plane is more vertical than horizontal, but decent imaging. No problems so far. And here's the long axis view. And the 3D here, you can see this is the so-called surgeon's view with the anterior on top, and you can see the flail segment up top there with the TR. So far, no imaging challenges. And I'm relatively new to EVOQUE, so this was an EVOQUE case. Once you get the hardware down there, though, with this horizontal heart, you can see that shadow in that transgastric kind of covering a portion of the anterior leaflet. And as the device and hardware comes down there, you can see that shadowing there in the lower left in the anterior leaflet region, between 6 and 7 o'clock. And thinking about it, it's like when you get the hardware in there with a horizontal heart, the device is coming in a little bit more horizontally in that right-hand view, and that creates shadowing because your sound waves are coming from the top of the pyramid there, and that can obscure the anterior leaflet. And so we were having some trouble assessing the arms in that anterior region where the flail was to see if we had enough insertion, and this is the reason. And the transgastric short axis actually gives you that view in the left too, and because the sound waves are coming from the top, gives you that same area of artifact and shadowing. So that doesn't really help you there. So we were having some trouble with that, and the thought is, well, you know, if we put an ICE catheter in, this is kind of just a representation of where the transducer would naturally go in from the IVC anteriorly. And you get the best images along the long axis of the crystals there. And when you go the 90 degree, you get a worse image. And that's why for TEER, you have to do some manipulation so you can get the perpendicular arms image better. But for this situation where the anterior leaflet is obscured on the transesophageal imaging, you know, we get this minus 45 to plus 45 region where you get the clearest imaging on ICE, and that just happens to cover that area. So when we went to the ICE MPR in the lower right, you can see the red plane coming into that arm there, and that corresponds to the view right above it. And you can see that flail segment on the left. And then we can just rotate using this, and then you go to the next arm, and you can see, okay, the leaflet on the left and that upper right is coming inside the device. And you can keep rotating for assessment. But then eventually it'll start getting fuzzy. But that was the area that we were having trouble seeing. And so we had difficulty, you know, confirming good leaflet insertion with just the TE, but that's where the ICE really kind of helped us to show that we just had that one arm where it wasn't inserting where the flail was. And that gave us the confidence then to deploy, and in the end, a very nice result. So I don't think I'm the first person to ever think about this, but it was new to me, and I think as ICE comes along, we think of it, Nadira has shown very nicely its utility with edge-to-edge, but I think with you know, EVOKE, since it is assessment of leaflet insertion, I think it has a role to be helpful when there is obscured segments. So basically in TTVR, patients with difficult leaflet assessment due to device shadowing, particularly with horizontal hearts, 3D ICE may be useful to better visualize those obscured segments. So just a thought there. Thank you.
Thank you, Richard. Beautiful case.
Yeah.
First TTVR with EVOKE. And Moody, a question to you. I know you've done so many with Raj. What are your thoughts about it, especially with TE, and how many cases have you done EVOKE with Raj using 3D ICE?
So I think we use the 3D ICE maybe in only 2 cases. And the reason for that is that it was free. That's why we used them, because it is expensive. Most of the time, we're able to get away with a TEE. I remember there was only one case that we had to cancel because the images were terrible. And the key to that is trying to go from a lot of different views. Many times mid-esophageal could be difficult. We go to transgastric. And transgastric, because you're closer, you get much more better imaging. And as you did the 3D MPR, we built the 3D MPR from the transgastric. And sometimes the 3D doesn't help much, so we go back to the 2D. And we start to look with a biplane, and you get a little bit better images. So between, I mean, the thing that I learned a lot with the tricuspid, that you have to be open-minded that you move to a different thing. You have to not only plan A and B and C, but up to plan E and F if you need to, with different ways of imaging it. And taking your time, if you're not confirmed, you know, take your time as you did. You know, if you're not sure about this leaf grasping, it's much, much safer for the patient and procedure outcome that you take your time and put a 3D ICE to confirm than just like, you know, trying to say that, okay, no, it will be fine or it will be a problem.
Perfect. No, and exactly. I love the diagram, Richard, that you use for the, how it plays and where the better adjustment and the higher resolution. And your thoughts about, Moody or Richard, in terms of 3D versus 2D visualization of the leaflets. I learned a lot once I moved to Minneapolis that really in terms of leaflet grasping, that I feel 2D is really good, especially in doing clip cases. What are your thoughts, the resolution between 3D and 2D? Especially in the Evoke, in grasping, ensuring the leaflet grasping, I know they use a lot of 3D MPR, but the resolution of it, I know a better improvement in the resolution will be coming in the software 11, I think, the Philips guys. But your thoughts about it?
Yeah, and I didn't show them. I had flipping back to the 2D, obviously the images are better, but then you don't have the reference of which arms you're looking at, when you rotate. So that's where the 3D MPR off of that kind of tells you exactly which arms you're looking at as you're rotating.
I'll just say that I think that it's probably less important for Evoke than it is for TEER devices, because with TEER devices, we're trying to get the leaflets to lay flat in the arms, and we want that to recreate the coaptation. With replacement, you're replacing the valve, and so if the leaflets are curled or pinched or even pinwheeled, there's a lot more tolerance for that. And we had a case, your Beijing case, where when you telecast it a couple of weeks ago, it's very similar. You just need to see something inside the arms. It didn't really matter how it was folded or not.
And for the Evoke, you have 9 anchors. If you miss 1 or 2 of them, it's fine. But with a TEER, if you miss 1 leaflet, it's not going to be good.
Exactly. Yeah.
So Richard, this was wonderful. I mean, even the explanation of the challenges and the shadows. And I mean, it was just, for me, it was great. I always ask Scott to explain it to me. He goes, "I'm not going to do that. We don't give kids dangerous tools." So I really appreciate you going through it step by step. The question I have is, how close are we in a systemic way, say, this is how we're going to do ICE, and like the same way we do a TE, mid-esophageal, deep esophageal, transgastric. I mean, it seems like ICE bring a lot more diversity to where we can put an advance, pull leftward, anterior, posterior, leftward, rightward. I mean, are we close to understanding ICE and how we're going to do ICE the same way that we do TE, or is it going to be, trial and error and experience?
Yeah, I think we're still learning, and Nadira has done a great job at explaining the steering and that sort of thing, which is definitely much more important with the TEER. And I think it's a different modality that most echocardiographers are not really used to. I mean, it's a new region, so I think it's getting familiarity with that, and then also learning what you're doing and what the goals are with the manipulations. So I think it's going to be an essential tool, especially as the technology improves and the angles improve and those sorts of things, but it's still a learning curve.
So thank you, Richard. That was wonderful. And next I'm going to ask our friends, Tom Waggoner, to get off the panel, and I'm pretty sure, Tom, that their difficult percutaneous valve replacement, you're going to make it sound easy, and we look forward to see how you did it.
All right, so I'm going to switch it up a little bit. I couldn't find a good snare case or a good embolized tricuspid valve case. I know Paul loves those, so I'm going to switch it up to a little bit more of a complex anatomy, because this remains a big problem for us, at least at our center, trying to tease out and parse out, do they get a TTVR or do they get a TEER? And that imaging section was very nice that was just presented. So the case is an 83-year-old male, BMI is around 27. He's got severe TR mixed degenerative etiology, class 2 to 3 heart failure. He's had a couple admissions for heart failure. He gets by on diuretics. We get him out of the hospital after a couple days, and he's back in within 3 to 4 months. It just kind of undulates every quarter, it seems like. Some chronic renal disease, likely diuretic-induced over the last couple years, permanent AFib on DOAC and tolerating the DOAC, which is a key point. High surgical risk, STS at 10% and 5% for repair and replacement. He had a TAVR back in 2020. So his anatomy was complex. He did screen fail TEER and other TTVR trials, and I'll kind of go through that in just a second. So this remains, though, kind of the clinical conundrum of how do we approach TEER versus TTVR. And this, I thought, was a nice case. So I'm going to take a step back and just kind of go through our assessment of the RV function, which I think is critically important when you do TTVR versus TEER. So PAPI greater than 1, a PVR greater than 3.6, a TAPC greater than 17, 14 by strain, the decoupling factor greater than 0.4, global strain greater than 24, free wall strain greater than 21%. So you have your invasive on top and your echo-derived in the middle, and then the bottom is a tri-score. Now this is modeled for surgical TVR, surgical replacement obviously, but I think it is and can be helpful. Low, intermediate, or high in-hospital mortality you can see here, and I'll go through some of the numbers. Tri-score, I won't belabor this, but again, it's a scoring system for surgical TVR and in-hospital mortality in 30 days. Again, low, intermediate, and high risk. And I think this can be helpful as you build your tricuspid valve program. Not every patient can tolerate a replacement. You have afterload mismatch, and these patients are in the hospital for days to weeks on inotropes. So our patient, PAPI was 1.8, PVR was good, PA pressures were normal, TAPC was 19, the coupling factor was good, strain was relatively good, tri-score, intermediate risk for an octogenarian. So this is our quick kind of summary we present at our structural heart team meetings every Tuesday. So relatively healthy RV, good function for an octogenarian, normal PA pressures, he's tolerating a DOAC, which again is important if you get a replacement, and his QRS was narrow. So initial strategy was TTVR. So we screened him at this time, this was about a year and a half ago, for Tricin 2, he was ineligible, and I'll talk about why in just a second, and then we screened him for Triluminate and Class 2 TR, and he was ineligible because of the following. Large anatomy, which is a problem because TTVR, end-stage disease, we're behind the 8 ball, right? The structures are dilated, the RV is dilated, the annulus is dilated, the right atrium is dilated, the cable systems are dilated. So I think this is really, really important. So 170 millimeter perimeter, annulus area of greater than 58, large coaptation gaps of greater than 10, large AP canids, which Paul, you initially taught me about a couple years ago. You probably don't remember that. Short, tethered septal leaflet. There was an area we probably could get a clip in. If this, now that Triluminate was approved, I'd probably consider doing something with commercial TEER. And the patient is eager to be treated. He's got an STS of greater than 10%, failed 3 trials, but he wants to be treated. So here's our imaging. We just put a couple clips here, the inflow and outflow views at 60 degrees with color. So 4+ we called it, short tethered septal leaflet. So we enrolled him in Laplace actually. We thought this would be an option for this gentleman. This is the transjugular system, and this is why another comment about transjugular. You can see the angle of approach in the cartoon image on the right side of the screen. I think it's very, very favorable. And then we're going to move to, this is the alternative axis for tricuspid replacement. It's going to be transjugular with 2 proglides, as I alluded to earlier. So it's got a diastolic anchoring tab called a DAT, a posterior engager, and a posterior flap, which is critical in the deployment of this valve, either with ICE or with TE. Has a nice anterior flap and a cuff, and also has a lead provision for a pacer port if you need to put a lead in. It's a 28 millimeter porcine valve. So here's our CT analysis. Again, it was about 170 millimeters, so 170-ish. It was a good fit for a Laplace large valve. They have a large and a medium. You can see at minimum about 4.5% oversized, and we've learned that if we go down to 3, we may have PVL. So around 4.5% oversized and works very well, up to 177 millimeters. So this case, pretty straightforward. Again, it's PERC-AX ultrasound. PERC jugular ultrasound guided 2 proglides, dilated over a stiff wire down into the IVC. So that is important, right? Using your stiff wire, your super stiff wire, or your Lundaquist into the inferior vena cava, and then dilate straight through the RA, and then put your large sheath in. A very nice angle of approach, very favorable. We do put an RCA wire in, at least in these early cases, just to confirm that we are near the annulus and not too far above or below. Posterior flap is the critical, moment where you stop and say, hey guys, are we where we want to be? That flap needs to be below that posterior annulus, so it anchors. If it does, it anchors very well. You don't want it to ride up. If it does, you can recapture it by resheathing, advancing into the RV, and then deploying a little bit deeper. The valve expansion in the RV, we pull back, we do anterior flap release in the RVOT, which adds some stability. You can see the valves moving here because the patient had AFib RVR at the time with contact with the RV free wall. And then we do our system removal. Pre-procedural image on the left of the screen, intra-procedural in the middle, and then our follow-up discharge echo looked great. So this is a 30-day, the patient did very well. Trace and unresidual TR, no PVL, mean grade of 1, and no conduction changes. Discharge post-op day 3. Just a brief summary. Again, I think transjugular approaches with TTVR is something I think we're going to see a lot more of, and just on the early cusp of it. So this system is primarily floral driven compared to the 9 tabs that Moody was talking about with Evoke, which I think can be an interesting feature. You can probably do it with ice in the future, I would guess, with enough experience. It seems the only critical component is ensuring the posterior flap is below the posterior annulus. It's relatively straightforward in terms of imaging in the inflow and outflow view. Not a lot of challenging deep transgastric views were required. In our first case, it was an FIH case we did in Tucson, and it actually took about 52 minutes, so relatively straightforward. At 3 months, the patient's doing very well, no residual TR, and there have been a total of 8 cases. The first 5 we presented at Inmate Valves last month. Thank you very much. So transjugular, percutaneous, 2 proglides, Paul.
Love it.
That's fantastic, Tom. One question, transjugular. I'm very conscious of my radiation, so is my colleagues, interventional. How do you handle that from the transjugular aspect?
Great question. So lead hat, lead shield, anything lead I can put in front of me to displace any scatter. So that remains, it is just like our axillary cases and our transcarotid cases for TAVR, right? Radiation exposure to the operator is something that we need to be more conscientious about. I think being above the diaphragm is going to be an issue with radiation.
And Tom, I'm going to ask another clarifying question, because I mean, some of those pictures, I even saw a hand in the, under the X-ray, trying to do different maneuver, but also how you manage the head of the table, or literally the head of the table. We have echo, TEE, anesthesia, the procedure. Yeah. I mean, I think there is a lot of procedures that we do from the neck, but there's also, in a way, there is a split about what people prefer in terms of access. I mean, the groin is similar to where we stand most of the time, but how do you manage the head of the table and all of the passing, maintaining sterility, sometimes bleeding? Right. What is the best strategy for people who are thinking about transjugular
Great question. So what we generally do is our configuration for axillary, carotid, or jugular is almost all the same. We have the table teed up to the side, the patient's arm down to the ipsilateral side. We have a TE anesthesiologist right above at the head, and we're immediately to the right side of them. So it's a the configuration is pretty fluent and pretty easy, I think, to set up. It's not that complex. But all 3 setups are the same, all 3 configurations.
I have a question. You had a very nice description of the anatomy or the pathology of the valve with a very big wide gaps, and hence and septal leaflet tethering, large perimeter. My question will be to the surgeons. I see Steve here in the audience. When would you decide to replace tricuspid valve, and when would you decide that, okay, this is repairable, giving all this complexity?
That's a good question. I mean, usually for us, if it's hugely dilated, and I don't know what hugely is, we're going to replace a valve, because the penalty we have for replacing it is not as much as a TTVR. Remember, our big valves are like at 29 or something. That's not at 52 or something we put in there. So, if the annulus is 6 or something like that, we're going to replace it, because I don't think, the RV's dilated. A ring will not fix that, because half the muscles will still yank it open. So somewhere, if it's big, it's the annular diameter that we think about replacing.
And this valve we put in, just to be clear, was a 62 millimeter.
Remember, the difference between a TTVR and what we do in surgery is TTVR has to be pushed out. That's how it's holding on, and we're bringing it in to make it small. So we're not as worried about exploding the RV long term. Tom, I have a question for you.
Yeah.
It's a great case. Interesting device. It has a big footprint. It's got like a flange and a flap and a tab and a thing and a ding dong and so like that. Do you have a special anticoagulation protocol? I mean, it's a slow flow right side.
Right.
This would scare us that we're putting a lot of stuff in there and they're just going to.
Absolutely. I think with TTVR, as I alluded to earlier, the patient could tolerate DOAC, which I think is really important. When you're thinking replacement on the right side, to Steve's point, right? Very low flow, very high risk of having thrombosis in the first 6 months, and possibly even beyond, right? In someone like this, he's 80. Yeah, I think that's going to be a real issue with tricuspid valve replacements, regardless of the.
These devices are special moving in for
6 months, it's standard. Yeah. So all of our tricuspids that are percutaneous, we do 6 months of OAC. Yeah. But beyond that, time will tell.
So Tom, I think I'm seeing this for the first time. I didn't make it to New York Valves this year. Is there any pucker moment in the deployment of this valve? I mean, as Steve was saying, there's a lot of stuff you're pushing out, but where's the point of no return? In terms, is it retrievable? Tell us a little bit more about the technology.
Absolutely, yeah, it's a great question. So there really is not a pucker factor for this. You know, it's very slow, it's controlled, it's prescriptive. The only thing that you have to be critically, you know, focused on is you have to have that posterior flap below the posterior annulus, right? If not, it'll pop up and then potentially embolize, I imagine, right? So you can recapture that almost through complete deployment. It's recapturable, yeah. But as long as you have the imaging that shows the posterior flap is under the annulus, that's probably the only time. And it's very controlled, right? You don't have the rapid pace, it's very controlled. So far it's been a success. We'll see what the data shows.
One question, maybe
Please.
I missed that. How is the RV function of the deployment and follow-up? Maybe I missed that point.
Sorry, repeat the question.
The RV function of the elimination of the TR, how was it?
So he did well. His RV function did not change, and that's why we screen these patients with that screening data set I showed you. I think it's so important. We've seen cases when you do a replacement of the tricuspid, the RV dilates, they have afterload mismatch, and they're in the ICU for a day to 5 to 7 days on milrinone to butamine and IV Lasix. So in those cases, we quickly go to TIR. If we can get TIR, we'll do TIR. So I think that's really important. This patient's RV tolerated very well, and I think being aggressive in your understanding of the RV function up front is really, really important. Thank you very much.
Thank you. And in addition to that, a point about RV function, and in adjunct to the morning sessions about talking about RV function, I think Moody, we talk about the multi-parametric approach, and I think Tom showed really very well. There's so many echo parameters in terms of assessing RV function, not just TAP-C. We use fractional area change, you use the strain imaging, and also the TAP-C over the fractional area change, that decoupling factor. So it was really, really nice to see that, and really advocate for all of us, the imagers out there, to use every single parameter in terms of assessing RV function. Yes, Moody.
Tricuspid not only require a lot of imaging modalities, but a lot of RV assessment modalities too.
Can I ask you a question about RV function?
Absolutely.
A device like this. So this patient, what does their TAPSI do once you put a big device in there? So how do you say to yourself, now the RV is down or better, besides just eyeballing and saying looks like it's squeezing better? Because all those numbers sort of go out the window when you have a big device in there like that. Especially, Tom, this thing turns up a little bit into the RV output.
Correct. Yeah, it's got a flap that goes in the RVT.
His TAPSI is how we check it by echo. TAPSI and the decoupling factor are the two that we followed. His were unchanged.
So you still think you can get an accurate TAPSI with the device like we put in a Predator, we put in a Vogue, and we do both of those. We got those things sitting back up there. We don't know what a TAPSI means.
Yeah, good, fair point, but in this case it didn't change. I just think we don't really understand yet how to assess RV function post any sort of replacement strategy in the tricuspid valve, because you change the geometry, you change the septal motion, you change how the LV interacts with the RV. So there's a lot to learn still how we assess RV function post any sort of replacement strategy.
I mean, and that's again part of the answer is post the transcatheter TTVR, we're probably making the annulus bigger, whereas in surgery, making it smaller.
But a lot of them are, I would just say that, but a lot of them, Steve, I think are trying to move towards a true fit approach. So, I mean, the oversizing, we're trying to minimize that. And the Evoke is trying to pull things in. V-Dyne is trying to true fit. This is remarkable because this perimeter, 177, I mean, other valves would have to explode the RV to anchor. This fits in like putting on a shoe. And that is probably the gentlest way you could treat the RV, which I think is quite remarkable.
And to that point as well, I think on the base of the RV, I think that's why this valve is really gentle on it. And probably that's why you see the preservation of the TAPSI, unlike the other valves where you have acute kind of shutdown of the TAPSI at the base of it, Steve. And you see in the follow-up of these cases that I see in the core lab, you see some of it actually improve and some don't really. And so really the other parameters that we use, fractional area change or the strain imaging and other, decoupling factors as well that we are still assessing in these trials. So more to come.
Yeah, I mean the hope, Steve, as you said, is like right now it's hardly ever that we get a aortic stenosis with a mean gradient of 100 just because we catch them sooner. the hope is we will not get the tricuspid annulus to get that big, and catch them sooner. And one strategy to do that is to show gratitude to surgery. So we'll let you talk about this topic. I think you're coming up next. Gratitude to surgery.
Do you need reading glasses for us? Are you okay?
So you gave Gaurav's talk, and Gaurav is going to give you a spot? I mean, okay.
Yeah, Gaurav is coming. He's in a car.
So next, then I guess Jonathan and Schwartz, we will not show gratitude to surgery. We will show a tricuspid case that's changed you, Jonathan.
All right, thank you, Paul, and then to the moderators. It's an honor to be here to present again. Again, kind of an interesting title I was given, a tricuspid talk that changed me. There are some points in here I'd love to get input. I know we say that every time. There aren't any tricks here, so sometimes when you're a panelist, you worry about I don't want to look stupid. There's no tricks, so just give me your honest thoughts as we go through this. So, disclosure. So this is a 51-year-old female, progressive dyspnea, bilateral extremity edema that was pretty massive when we first saw her. Some pulmonary edema with some hospitalizations, inability to work some shifts. She actually worked at the hospital that I practice at. Found to have severe TR under echo, diastolic dysfunction, some mild pulmonary hypertension, not too bad. Hypertension, diabetes, protein S deficiency with some DVTs and a PE in the past, and she's on Coumadin currently. Morbidly obese with a BMI of about 41, 42. And sarcoidosis that was limited to pulmonary and ocular, that was biopsy proven, and she had a very thorough cardiac exam with biopsies and everything and had no cardiac involvement. Intermittently on methotrexate and steroids for her sarcoidosis. Had been followed in the heart failure clinic. They're actually the ones that referred her to us, and they felt that she was on the maximally tolerated meds at the time. Imaging, when she first came, not great. She had not had a TE yet. It was really just the TTE. Just nothing too bad, I guess. And you make note the RV doesn't look too bad here. We did get a TE then, and the pictures were somewhat limited. Not great. You can see the TR there and transgastric view there. I don't know if I can go back and play these again, but try to give you guys a little bit more ideas what's going on here. We actually ended up having to get another TE. One of our more subspecialized imagers went back and did some pictures and got a little bit better pictures this time because we were worried that the imaging alone would limit our options here, but kind of see what's going on there now. And the area there was about 4.5 with the orifice. We initially tried to get this was kind of a theme in her presentation. Things kept happening, like she showed up for her right heart cath, but her INR is 5. We tried to go brachial, but she didn't have good access. Eventually got it. Right heart number is not too bad. She actually was as optimized as heart failure thought she was. This was very early in our experience. We were still kind of evaluating her for surgery as well, just for completeness sake. Coronaries looked fine. So to sort of summarize, we have severe TR, normal RV size and function with a pretty short septal leaflet that's tethered. The leaflets are a little bit thickened, but not too bad. The valve orifice was 4.5. The gradient was 1 at a reasonable heart rate. The gap was only 3 millimeters. We had a heart team and a cardiac surgery discussion. They wanted a CT and an MRI. The patient really wanted to avoid surgery for some social reasons, and she had a family member that went through a surgery and had a traumatic experience. This was before the Triluminate study actually started, even though had it started, she's 51 and had private insurance, so that was going to be a little bit confusing, so kind of difficult. The CT and the MRI, nothing too abnormal here, a little bit dilation, as you would expect of the RV, but nothing that was a surprise. So what do you guys think? Where do you go with this patient? I wouldn't say it's not possible, but I think we had a question about it. It's not the biggest septal leaflet, but this was very early in our tricuspid edge-to-edge repair experience too. So we were maybe a little bit more wary than we would have been now.
You obviously didn't have a TTVR if it was that long ago option.
No, nope. And we didn't, 3D ICE wasn't even out yet.
Yeah.
The lethal link did, I mean, obviously our experience again in tricuspid TEER has changed dramatically over the last year for us, just from case volume alone. So I think this would be a case that you could TEER anatomically at this point.
Yeah, I mean, it's a learning curve that we have with a TEER, and the same curve that we had with a mitral side, we're having with tricuspid side, and I see results now that are very, very excellent, and we know how to pick up the patients very well, and we get a very, very good results with it. So this patient nowadays, today, if we have decided to do it, I think TEER should be the first one on the list. Yeah.
Is Steve still here? Any surgeons in there? 51. She's morbidly obese. Morbidly obese on dialysis, has some people that are dependent on her. She's really worried about recovery. She's had a. Ask a surgeon.
You would set yourself up for those are all nice things and everything, but her surgical risk can be very low, and you set yourself up with a large, prosthesis that we can put a valve again her. She's not going to do well with dialysis, and it is a consideration. And I know, I think I can operate on everybody, and I say, well, but she will calcify a prosthesis you put in. So it's not just as easy as thinking, oh, she needs an operation. But if I think about it enough, I think she needs an operation.
Yeah, we definitely gave it a full thought. So all good
Steve,
ideas.
Can I just ask though?
Sure.
What about the likelihood of you replacing this patient? I mean, how does that factor into things? So, and the reason why I'm asking is to say, if you're more likely than not to replace, is it not reasonable to do a transcatheter repair first, knowing that you can put off the replacement as long as possible because she's on dialysis, because whatever replacement we put in is going to start a life cycle.
If you thought you were going to have to replace it, then I'd say maybe we could TEER, but you're not going to have to replace this. You'll repair this, you'll do an annuloplasty, it'll be fine.
Okay.
So let me think again. No, she needs an operation. So because the repair is actually what you want, right? That's what a TEER is. It's a repair. She won't calcify her own tissue as much as she will prosthesis putting in there. So.
And then are there, it's smart, both of you, are there things here that you do at surgery that are interventional friendly for later? I mean, just asking the question. So I mean, like when you do incomplete rings and such, that makes the risk of PVL go up. I mean, are there things that interventionists would ask surgeons to make things better for us later on?
For us, we put in, if we're thinking, and we are now always thinking ahead like that, I will personally put all the rings that I put in tricuspid are semi-rigid so that we can prop something into it at a later date. So nobody really uses a completely flexible. They're a little bit non-planar, and I think we put, valves in them later, and it works out pretty well. And you always think you're going to get down, between anteroseptal down by the AV node, you're going to get a massive leak, and you're not. And I think for us, that even if you get a little leak there, you're not going to pay the same price you do on the mitral side. You're not going to get hemolysis. So I think it's, we consider everything for this, obviously, because of her dialysis. Morbidly obese doesn't bother us, but she's 51. So if you start a patient down the TEER anatomy, when that goes wrong, in a couple years, then what are you going to do? So I would think surgery first would be a good strategy for her.
So question to Jonathan and the panel, and Rishi introduced a new concept to us, which is put the patient on a plane and send them to Europe. So, let's say, for example, Cardioband, annuloplasty. Cardioband has CE mark in Europe. The trial is under EFS is undergoing in the U.S. And let's just say it was available. Would that be a good option for a patient like this? TEER may be challenging. We're talking about annuloplasty. She's young. She's 51. We're thinking about future options and lifelong management of if she end up with a valve replacement. With an annuloplasty, should it be available? Would that be a good option for this patient?
I think that's great insight. For us, I think that would make sense for these types of patients that may be surgical, unless you're Steve Bowling, then they're going to be surgical. I think in this case, if she was
deemed not a surgical candidate, I think that would be a great first strategy. It preserves your tear, it preserves future intervention. So I think more and more as we get more data with that device, we'll understand where does it fit for both mitral, tricuspid, right? If we can do a percutaneous annuloplasty, it would preserve tear on both valves. It may help preserve some of the septal function and then maybe not exclude even a replacement strategy in the future.
I mean, I think so, as long as it matches a surgical predicate, right? And so the cases that we've seen have been actually really quite impressive. But it's just the procedure is complex and there's still some prediction issues. I mean, Moody, you have a significant experience with Cardioband. What do you think?
Yeah, it's again, it's a very tedious procedure, and when it works nicely, but it's very tedious procedure. I think there's going to be a lot of enthusiasm to bring it back and simplify it, because it works, and it's going to be very, very helpful to complement all the therapies that we have right now. So it's just going to be a matter of how can we make it sure that it's going to be anchoring correctly, how can we be sure the imaging will be easier. Now the imaging have improved a lot with the 3D eyes, so I think it will be coming in the next future, yeah, in the very, very near future.
Again, this is the kind of problem we get when we talk about catheter-based things is, catheter-based, we have one thing, you can only use one thing. We would never go in a mitral and just do an alveolar. We'd always put a ring on it. In these cases, when we do an annuloplasty, we almost always bicuspidalize the septal and the posterior leaflet together, which gives us a much higher success long-term, against recurrence. So, these are the kind of things that if you said we had available for this lady at Cardioband and a clip at this point in time, I think that'd be great, but we don't.
But don't you think, Steve, that the opportunity for a catheter based on the tricuspid side as a surgical predicate, there is an opportunity for ring only, unlike on the mitral side where you do have the toolbox, which is larger.
Yeah, I think, and also the tricuspid space obviously is far more forgiving, if you will, for catheter-based therapies. I think we abandoned, obviously, I think personally we abandoned ship on the idea of a tricuspid annuloplasty too early. And you're right, it's very difficult in a 10-hour, Cardioband, no one's going to do it. I mean, some people do it, but it just won't be clinically applicable. I think we have to go back and revisit that concept of somehow increasing coaptation, Roman arch keystoning, but not 10 hours.
Maurice, you have a comment there.
Yeah, so, I know this patient is young, right? So it's really consideration what, how do you set that patient up for long term? And you might just know what kind of doctor surgery for this patient. And maybe as a first question is, who on the panel in the room is currently using the isolated tricuspid valve surgery risk calculator? No one. Who is aware there's an isolated tricuspid valve risk calculator? Okay. Four hands up, but no one's using it. So, I mean, we talk about surgical risk, maybe, that's important for everybody to know that there is a isolated tricuspid valve risk calculator. You really want to talk about what's the surgical risk. And then, the question was asked, what would you do to set up the patient for success and help out interventional cardiologists? I would do a mini, so there's not going to be external wires. Sorry, Steve. I think mini is a good way to do these, but sternotomy is fine too. But what I would do is I would put a ring on it, and if I felt like there's going to be a lot of pull on the annulus, I would have a low threshold to augment leaflets. You do these on the beating heart, so you don't have to rush, so you have the time to really do something that's going to last. I started using the thin vortex membrane because I think all the pericardial stuff, autologous or otherwise, will contract over time. But really, if you have FTR or functional MR, the valve is too small for the ventricle. And there's nothing that's really going to remodel the ventricle quickly. So in some ways, maybe the best thing we can do is augment the valve. And I mean, there's transcatheter technology that tries to accomplish that very thing. But if you take someone like that, you put a ring on it and you really spend some time, I think you can set them up so that they will have a good result and they will have the option down the road to get a clip or indeed get a valve replacement.
All right.
So, Jonathan, it seems like this case not only changed you, it's going to change all of us.
Apparently.
So we're very eager.
We're not even to the exciting part yet, honestly. So we did offer her surgery, but we thought, she wanted to avoid it. We thought, let's give it a try with clipping. I know.
Can I just make a comment on that? There's not a single patient out there who says, like, I really, really want heart surgery.
That's not true. That's not true. I've had patients that come and say, I want surgery. So it's not often, but it happens. So we planned edge-to-edge repair here. We did not have ice yet, so it's just going to be TE and fluoroscopic guidance, starting septal anterior and then septal posterior. We anticipated multiple clips, probably would have some residual TR. Everyone agreed after our discussion, and we talked to the patient about it just to make sure she was okay with it. So getting to the TE for the imaging procedure, really no surprises on the table. The TR was still just as bad as we thought before. Going in, lots of trouble trying to get the anteroseptal leaflets to come together, and actually at one point probably tore a cord, and it was the TR got a little bit worse. We switched over to the septal posterior approach with the same clip and was able to get a modest reduction with a smaller jet. And the gradient was 2 at that point at a heart rate of 86 with an NTW. And so now we're going to see if maybe going after the anteroseptal area was going to be a little bit easier. And so this is just after first clip, gradient to 2, modest reduction in TR, but still enough that we wanted to keep going. Get a second clip on, this time on the septal anterior leaflets, it was okay. Gradient was 5 at a heart rate of 80. And you can see, I think I have color here. A pretty good reduction. We slowed our heart rate down a little bit. The gradient was 4 at a heart rate of 70. TR looks great there. The clips look great. So we thought, okay, this is not too bad, and things look good. 1 week follow-up, the patient had lost like 15, 20 pounds, I think. Abdominal distension was much better. Her edema was noticeably better. She said she felt like a new person. Still had a little bit of mild dyspnea, but her edema was still much improved. We did end up getting an MRI and a CT, and things showed the clips were in good position. The TR was improved. The RV size was improved. Does anyone have any concerns at this point, or do you count this as a win?
Sounds very positive so far.
So that's kind of what we thought too. There's more to the story, of course. I'm not just going to show a boring clip case here, right? So at 1 year, things still look good. The gradient now is up to 6. There was some concern, maybe is the sarcoid maybe causing some granulomas or something, or what's going on there. I'm not totally sure. Maybe it's just normal healing, but she still felt decently well. Starts having some hospitalizations. 18-month at her follow-up visit. Another hospitalization that she was in there for a while. The TR still looked good. The gradient on the echo during the hospitalization was still only 5. She kind of optimized her with some meds. She, again, was like, oh, I'm doing okay. She pretty reluctant to try to do anything else. She ended up having some orthopedic issues. We kind of lost her for a little bit, but then she came back at 2 years, and now her gradient is 12. TR still looked great, but the valve was a little bit too tight. So we kind of squeezed it to death, I think. So had a heart team review. We thought, it was very likely from the clips here. The ventricle and the gradient, or the size and the function still looked good, but there was still a little bit of concern about the granuloma. We thought still she was an acceptable surgical risk, and she did end up undergoing surgery, got a 31 mosaic. They did not see any granuloma formation on the leaflets or clips, so that was a little bit interesting. But this was a case that really changed me, because we really didn't have any concerns at the time. We thought, we're still sort of figuring out what's an acceptable gradient here. Maybe earlier on, some of those follow-up hospitalizations, we could have gone through this a little bit sooner, but it was kind of hard to predict that this is what was going to happen. So I think even in somewhat low-risk anatomy, stenosis can occur, even with what you think is an acceptable gradient. Maybe they develop over time. It's hard to know, hard to tell the symptoms. She's on dialysis. Is she just not getting complete dialysis? Maybe that's part of the overload issue, so that maybe complicated things a little bit. And as usual with every case here, I think heart team approach is vital, and the imaging definitely made this a much easier case. So just want to acknowledge my partners and everyone that I work with, and thank you.
Beautiful case. I remember one of your earlier slides, you mentioned the tricuspid valve area the baseline was 4.5, that in itself already is a red flag. That putting 2 clips, you would have reduced it down to less than 2. If you think about it, for the mitral valve, when you put in with a valve area of 4.4, you put 1 clip, you halve it, and you put another clip, you're going to reduce it further. And I think a normal tricuspid valve area, Steve, correct me if I'm wrong, is at least, I would say 6 or more. It's big. So with a starting valve area, right, Moody, for 4.5, you would have anticipated, now despite the mean gradient being 5 or 4 post-procedure, which was great, and she did have an improvement, I would say don't be skewed by the mean gradient. I think Paul knows that, I always love doing my 3D valve area after mitral clip repair, just to see the valve area for each of the orifice. So that's my suspicion that she probably already has that stenosis after 2 clips on the tricuspid.
It's exactly right. I think that was another, I should have put that as a learning point, but we paid a little less attention to that back, 6 years ago when this first presented, but we definitely pay more attention to it now. I wanted to see if any of you were going to catch that when I put it there, but I didn't want to give away where the case was going. So
it brings up a very important question that Firas asked initially, is like, when should we stop? When we should say that this reduction is enough, even if we have a moderate, PVL leak, even if we have a moderate TR left, when should we stop, and when should we put, when we should be trying to really reduce it to mild TR or no TR? It's a very, very important, because not because we can do it, we should always do things. So I'll leave the question to the panel, is like, when do you think should be the balance between, that's enough, or no, we should always do more?
Well, I think we should try to get the leak as less as possible without causing harm. And here, the gradient was 5 when you were done. What I'm trying to understand is what caused it to go from 5 to 12 in follow-up. Is it an error in measurement, or was it because she's on dialysis and she had some reaction? Did they see anything at surgery that would explain like
nothing
a big
at all.
keloid or
No.
something?
That's what we thought. We thought maybe the sarcoid got in there or something, but no, it looked like it
so
was.
the clips are just normally placed and everything, and
Yeah.
Okay.
And then the hemodialysis patient, it can be difficult, of course, high output state and all that stuff. I'm not saying she was obviously worse clinically, so something was going on, but she had been lost to follow-up, medication non-compliance. So I think these fistula patients can be very tough to assess hemodynamically. The other thing is, how many people have seen TS post tricuspid tear? I haven't seen one.
No, it's rare. It's only a handful of cases in the
saw one?
IDE. Yeah.
Especially in the end-stage renal disease patients. These are the patients that I struggle and fight a lot to tell the cardiologist that this is a moderate TR. You don't need to put another clip in, because this is just going to be enough. We're not going to cause any harm. We reduced it. That was our goal.
Right.
But it's always a battle that is like, no, it's a very, very simple. We should put another clip in, versus no, we should leave it. It's good enough results.
And those people can dialyze 4 times a week instead of 3.
So you're saying you see this more in the dialysis patients?
With dialysis patients.
So this is this just a high output flow phenomenon?
High output flow state, and for some reason they start to develop calcifications, and it just becomes more that you see we put one device or one clip in them, and we see an improvement. Elevation in the gradients. Once we start to put 2, we stop completely. We don't want it to get any further.
Okay.
Yeah, and I do think it's more than just an error in measurement, because she definitely got improvement, in the first year after we put this in, and then got worse. So, yeah, I agree with that.
So we have 5 minutes until 2 important things happen. One is lunch, and 2, Gaurav arriving. But I want to ask a question to the panel, because we struggle with it all the time. How do we measure tricuspid stenosis? Whether it's after TEER or even after TTVR. We finish the case, and the gradient is 2. Let's just say it's TTVR, and then at 30-day, it's 4. And it's still low. But is that stenosis? Do we worry about it? Do we start looking for halt and leaflet thrombosis? Same with TEER. What is an acceptable gradient at the end of the procedure, and how, because, Paul, your comment was spot on. It's like, if it is 2, that's great. Well, if it is 4, is that not good? Should we take out the second device if the gradient jumped to 4? When should we stop? How we measure this tricuspid stenosis when the differences in the absolute differences in the gradients are very small.
Looking at me.
Yeah.
I
Gradient
mean,
alone is not going to be the answer for sure.
This is very similar to the controversy we have for mitral. You know, I mean, and if you look at the recent prime MR data, they'll tell you gradients don't matter. But, you know, there's some controversy about that too. And they'll tell you that MR reduction matters much more than gradients. I think it's very similar for tricuspid. You know, and the challenge here is that somebody who gets a high tricuspid gradient despite reducing TR, they're going to have worse pathology. There's going to be some reason why that gradient is higher, and it's not necessarily always just going to be the iatrogenic causes. You know, it could be the valve area is small to start with. Well, why is a valve area small? Well, you know, there are other reasons that might be present that are associative, not necessarily causative. And so I don't have any foggy idea as to what a high gradient would be. We set it at 5 in Triluminate so we could have something to report, and there were a handful of patients that had gradients more than 5. There weren't any clinical sequelae because of that, but you know, so this patient would have fallen easily within the non-reportable cohort for patients in the study.
Yeah.
If that means my output's good, then I'll take it.
Yeah, and what's the TR?
Yeah. Don't get me wrong. I'm not saying gradients, we should not ignore them. I would never say that. But it is hard to decide in the procedure what is significant. And no, we do not. Yeah.
Yeah, I agree. Our target's 3, you know, but again, to Paul's point, is it's sometimes hard to predict. And you'll do an echo the next day, and the gradient may be 5, 6, or 7. So it's remarkable how, you know, the mismatch that you see, and there may be some component of discordance like we see in small valves in the aortic position, I wonder. So, but I think that's something that we try to be, to Steve's point, as low as possible, you know, and it's hard to understand, you know, does taking that clip off change the MR or TR versus the gradient, and what's that balance? To Paul's point, I agree with you. Sometimes it can be very gray.
Well, I always tend to add 1 or 2 to whatever the TE says, because the next day it's usually about 1 or 2 higher, regardless of the heart rate. But to Marvin's point, I don't know how we can stress these patients. I mean, for mitral, we give phenylephrine to check, kind of like your water test in the OR. But for tricuspid, I don't have the foggiest idea. I mean.
And so, you know, back to the number 5, how do we come up with it and why was it in the Triluminate trial, is really back to the ASC guidelines of definitions of tricuspid stenosis that was back in before the early 2000. So the 5 was that cutoff, and obviously the guidelines hasn't been updated since for the definition of tricuspid stenosis. The cutoff was 5, and so that was used from the Triluminate trial to now all trials. in the core lab. And so, back to the mitral clip, Marvin, your point that, we echocardiographers, the imagers in the audience here, for the mitral clip, we advocate a lot in the community about 3D mitral valve area, doing it pre and post. And in terms of if you need another clip, what are you reducing the valve area from 1 to 5? We always have the discussion in the cases, and we believe even Steve in the tricuspid, we do that too. There's a lot of shadowing, but it's doable. And looking at the baseline with that case, Jonathan showed the tricuspid leaflets itself tethered. The baseline is 4.5. It's going to go down to like tricuspid stenosis. You're going to cut it down so much. And so we in the echo community really advocate for 3D valve area in the cases. TDS, we are pushing very hard towards that. So much more to come on that front.
Yeah, I think we fall into this trap where we say like, oh, that gradient must be driven by residual TR. There's a lot of TRs falling back and forth, so the gradient's high. So we'll put another clip in, and the TR will go down, and the gradient will go down. I don't believe that very well.
It happens sometimes.
That's real.
Sashin, yes, go ahead. Welcome.
Good point. We use it, from most of the cases, I think we huge advocate for it, even in the recent guidelines for the structural imaging pre and post procedure. Hepatic veins, absolutely pre, and we do see an improvement, but note that if you see still hepatic vein reversal after a clip and you look at the color Doppler, it's still trace or mild, don't be alarmed. Look at, there is a systolic reversal, you can see the VTI actually improve. And so we are looking in the trial of that in terms of the reduction of the systolic VTI, showing an improvement, correlation with the TR regurgitation and outcomes. And that's because you still have TR reversal, which I see in the follow-up of these patients in the trial, and that's because of the non-compliance of your right atrium. And so measuring that systolic VTI, that reversal, you see a reduction of it, and then correlate with intraprocedural session that Paul does in the RA pressures as well drop. I think that's very important.
Absolutely, Nadira. We do the same thing, both VTI and hepatic vein. Hepatic vein for us is like the pulmonary vein. It really is. To see the flow changes, the flow reversal and improvement of that, I think is really, really important. I just want to say one quick point. If Jonathan's still here, Schwartz, when you do the 29S3 valve and valve for that case, go transjugular with 2 pergolides.
Paul, you're going to say something?
Oh, no,
I think if we come up with a new prize for the case that strike the most discussion, I think Jonathan will win.
Yes.
For this morning.
For sure.
So I think
we'll punt. Yeah.
Yes. So I think Gaurav we'll start with him in the afternoon.
So Gaurav Alawadi has tried his darndest to get here to make it in time for his presentation, but we're going to have him speak at 1:30, and he'll kick off this afternoon. So if all of us could come back